Hello, everyone. Thank you for listening part one of this presentation. We will continue the rest of the presentation from where we left, and specifically, we will be talking about discussing about the objective measures of pain mechanisms in this part.
PSI is a 40-item question, sorry, a 25-item questionnaire. So it has 25 questions that are reflective of central sensitization scored on a 0 to 5 scale. And if the overall score is greater than 40, one can say that this person or participant may have central sensitization. And the questionnaire itself has some limitations. They say it captures mostly the psychological part of it rather than the central sensitization part of it. There's been more criticism on this questionnaire recently, but currently this is the one that is available and commonly used. I tried to find any Indian adaptations of this questionnaire. There is one study that has translated this questionnaire into Gujarati version. I think this group is from Gujarat, and I couldn't find any other translations in the limited search I did in the last 1 week. I'm sure if you do an additional search, please let me know, and if there are other translations available for this questionnaire. Now, moving ahead, I want to talk about the psychophysical tests. So these come under the bracket or the umbrella of the quantitative sensory testing. So essentially, it has three tests that we do commonly in our supervisor's lab. So we do first pressure pain threshold using an algometer. So here we apply a gradually increasing pressure to the knee joint and also at the remote site, and we ask the participant or the patient to report when does this level of pressure is being perceived as pain. So the point at which this pressure is being converted to pain, we want that level of pressure. We do this locally, and that is at the knee joint, and we also do it remotely, and that is around forearm we do usually. And studies have shown that patients with knee osteoarthritis tend to have lower tolerance to pressure, means they have pain very early or with only low amounts of pressure compared to healthy controls. And not only they have reduced pressure pain thresholds at the local site, they also have reduced pain pressure thresholds at the remote site as well. That is as in the forearm. So earlier I talked about widespread hyperalgesia. This kind of corresponds. So the changes are more general throughout the body, not just limited to the local knee joint. Now, one of the limitation of this pressure pain threshold using algometer is that there are no normative values. Every individual will have different thresholds, and it is not plausible to actually have normative values. But what we do here is we take the values as a group, and within the group we classify people as having low pressure pain threshold and having high pressure pain threshold, right? Based on that, you can infer within the group who are more sensitive to pain and who are less sensitive to pain. So that's the interpretation we do with respect to pressure pain thresholds. In addition to pressure, you can also do cold pain threshold, and which essentially involves where the point at which the cold is perceived as pain. And we also can do a heat pain threshold as well. But pressure is more commonly preferred, given that some of these patients will have neuropathy, which makes the testing actually difficult. Here in our lab, what we do is we exclude patients with neuropathy from the testing. Next, moving to the two of my favorite tests, that is temporal summation, and next one is the condition pain modulation. These two are my favorite tests, I would say. So in temporal summation, what we do is we apply repetitive noxious stimuli to the hand, to the upper limb, usually over the volar aspect of the forearm. So I repeat, we do repetitive noxious stimuli. As you can see in the picture, in the green line, the top green line shows when there is a repetitive painful stimuli, the amount of pain experienced with each stimuli is usually or ideally same in a normal healthy participant. Right? If there is no central sensitization, each stimuli will induce same amount of pain. But what happens in case of central sensitization is that each successive stimulus will gradually increase the amount of pain that is experienced. So if you recall, this corresponds to amplification of amplification of pain signals at the spinal cord level or within the central nervous system. The stimulus is the same, but the pain intensity is increased gradually over time with a repetitive stimuli. Um, so we usually take measurement of VAS at first stimuli and the last stimuli. Normally, you ideally want the VAS to be same at first stimuli and last stimuli. If there is increase in VAS or visual analog scale of pain, that means the person has central sensitization, or this corresponds to a wind-up like phenomena at the spinal cord level. So this amplification, one of the term that is used is wind-up, right? And the next test that we do is conditioned pain modulation. So here this test essentially examines the paradigm of pain inhibits pain, or it tests the descending pain modulatory systems or the endogenous pain modulatory systems. As you can see in the picture here, what we do is we apply a first test stimulus, which elicits some X amount of pain. And in the second part of the test, we apply a conditioning pain stimulus, the second painful stimulus, in addition to the test stimulus. If you see in the bar, the length of the bar is less, which means the second in the second test, the pain should be lower because you are inducing an additional test stimuli or a painful stimuli. So we are basically testing whether the pain inhibits the pain. I repeat, just for clarity. So first you do a test stimuli and record the pain. And next you do the test stimuli in addition to the conditioning stimuli. Both are to be painful. Both test stimuli and conditioning stimuli to be painful. So when you record the VAS in the second instance, you expect some amount of descending pain modulation happening and the VAS to be lower in the second instance than the first instance because there is an additional painful stimuli stimulating the descending inhibitory systems. But what happens in persons with impaired descending inhibitory system is that there is no inhibition of pain, there is no reduction of pain. Here I'm showing the picture of what is expected, but in cases in patients who have central sensitization, the pain levels will be same even with the test stimulus and conditioning stimulus, or sometimes even more. That is when you say, okay, this person has positive central sensitization. So now I have talked about some subjective features, objective features, and then psychophysical tests. You infer central sensitization based on the responses to these tests. And I also acknowledge that the clinical translation of PPTs, TS, and CPM is a bit of a challenge. Now, there have been attempts to make these tests more feasible, more concise, so it could be translated to clinical practice. But at this point of time, to my knowledge, I'm not aware if any of these tests are in clinical practice. I do acknowledge the translation is a challenge. So that is about central sensitization, assessment of central sensitization or recognizing central sensitization. Now, briefly, I want to talk about evidence for CS in knee osteoarthritis. There has been a recent systematic review, which is a collection of individual studies, which has essentially concluded that 20% of participants, you can see in the left bottom, 20% of participants with knee osteoarthritis tend to have some signs of central sensitization. That is the estimate that we have to date. And I directly went into the conclusion in the interest of time. So when you see there is like 20%, I assume would be 1 in 5. So if you see 5 patients with knee osteoarthritis, there is a high probability that one of them, the dominant pain mechanism would be central pain mechanism, right? Next, this is another, I want to share another interesting study. This is one of my favorite articles in the recent times. So this study looked at the predictive value of QST measures, the quantitative sensory testing measures that I spoke about, the predictive value of PPTs, temporal summation, and CPM, conditioned pain modulation, in predicting responses to treatment, right? So this is again a systematic review, which is a collection of individual studies. What they looked at is whether QST prior to the delivery of a particular treatment can predict response to the treatment. So again, I would directly jump to the conclusion. You're more welcome to read the entire article, very interesting ones, especially the second one. So this is the conclusion of this systematic review, which says QST parameters were associated with poor outcome after total knee arthroplasty, NSAIDs, and exercise-based therapies, which suggests that patients with a pain-sensitive profile or who have pain sensitivity are less likely to respond to these standard pain treatments in case of osteoarthritis. So I'd like to paraphrase or rephrase it. So which essentially says that if you do a QST prior to the delivery of treatment and classify the participants as having central sensitization, so the participants who have central sensitization tend to have poor response to these standardized pain treatments. So the QST could predict the response. If you don't have central sensitization, that means they could have better treatment response with these standard treatments. Now, I also want to add this: the quality of research may not be perfect, may not be ideal. There are limitations, but the overall conclusion is this, and definitely future studies might change this conclusion to my understanding, but. But there is value in these measures in predicting responses to commonly used treatments. So that is about central sensitization. Next, move to psychological factors. Recognizing psychological factors is more straightforward compared to central sensitization, I would say, because you have validated questionnaires for each of the construct that I have said earlier. You have pain catastrophizing scale, fear avoidance and beliefs questionnaire, etc., to identify various psychological factors that I mentioned. You also have the long forms of the questionnaire and also short forms of the questionnaires. And short forms are like, say, if a questionnaire, say, pain catastrophizing scale has 13 items, long forms might take a long time to apply in a clinical setting. So short forms are preferable, but short forms compromises on the validity, and that's a trade-off there. But short forms are also there. There has been work going on to validate these short forms as well. And I try to again find any questionnaires that are translated to Indian languages. This time I could find a fear avoidance belief questionnaire, which is translated to Marathi version. But this has been validated in chronic low back pain population, but I assume it could be used in knee osteoarthritis as well, given given the pain being musculoskeletal in nature. So um, yeah, I'll just tell this point a little later. So overall, to summarize, I want to say the pain experience is a combination of peripheral, neurophysiological, and psychological factors. Peripheral being the structural abnormalities such as meniscal damage or synovitis, which in turn is influenced by some biomechanical factors such as alignment and quadriceps function. They do play a role. I haven't discussed because I assume they are more commonly discussed, but they do play a role. In addition to the peripheral factors, you have the central factors such as temporal summation of pain, impaired descending modulation, which can modulate the pain experience in combination with psychological factors such as fear avoidance and pain catastrophizing. Now, in an individual, all of the three aspects or all of the three mechanisms might be operating. And in some, it could be only one. It could be only knee pathology itself. Only peripheral pain could be possible, and it is also possible the peripheral structures may not be the active source of pain, and the pain is purely driven by central mechanisms over a period of time. And the last point I want to highlight is the feasibility of applying the questionnaires and tests in clinical practice. I have touched upon earlier, but at least I think psychological factors are fairly easy. Now, I have been hearing from colleagues in India, they would prefer to do it in a more informal manner instead of questionnaires. They want to assess the psychological factors just in an informal manner. So I think that is also acceptable as long as it is improving the uptake of these factors clinically. And moving ahead, I want to talk about the inter-individual variability. Just this picture might appear a bit too much, but then I'll try to simplify this. So here you have two patients, patient 1 and patient 2. Patient 1 is represented by white line. Patient 2 is represented by black dotted line. Each box represents the severity of a particular pain mechanism. peripheral pain, psychological mechanisms, and then the pain neurophysiology. And the last box represents the overall amount of pain, the lower end being less severe and the upper end being more severe, right? So if you see on the right end of the box, these two patients tend to have more or less same amount of pain, right? And if you see the first box, they have similar structural pathology, and if you see the third box, they have similar amount of sensitization. But you see the second box, they vary in their amount of psychological distress. Patient 1 has more psychological distress, whereas patient 2 has less. So though their pain intensity is same, the underlying mechanism is different, right? So I would like to say that patient 1 might benefit more from psychological interventions than patient 2. So with that, I would like to transition to the rehab implications. So the most of the talk I wanted to focus on the mechanisms and the assessment. Rehab implications are more limited, like in the sense that the evidence is limited. It is more hypothetical at this point of time. I'll talk about it so now. So broadly, management guidelines for knee osteoarthritis classify the treatment options into core treatments and adjunct treatments. Core treatments are the first line of treatments, which are to be delivered in all the patients with knee osteoarthritis. Adjunct treatments are considered as second line of treatments to be delivered if the core treatments are not being effective. So patient education, weight loss, and exercise, they are classified as core treatments for knee osteoarthritis. Electrophysical agents, manual therapy, medication, and orthotics, and many others are considered as adjunct treatments. And now one of the point that I want to mention is that less than 40% of patients receive first line of care. This is mostly the international data. There has been research done across to look at the commonly prescribed treatments or commonly received treatments by patients with knee osteoarthritis, which says a little less than half of the patients are receiving the core treatments, which means that there is greater scope to increase the uptake of these important treatments in the patients. So next, about linking the talk to the pain mechanisms to manage pain and hopefully function in knee osteoarthritis, I would like to classify the commonly used physiotherapy treatments under two baskets. So the first basket involving electrophysical agents, exercise therapy or graded activity, lifestyle interventions such as improving sleep, physical activity, etc., and mind-body therapy such as yoga, tai chi, qigong, and meditation. I've taken the liberty to include yoga and qigong in physiotherapy. Whether it comes under curriculum, I'm not moving towards there, but I've just taken the liberty. I'm classifying under in this basket. And next you have another basket which involves pain neuroscience education, manual therapy, cognitive functional therapy, and brain-based treatments such as transcranial magnetic stimulation. So the reason I put them into separate baskets is that I classified them based on the amount of resources that are required. So generally, electrophysical agents and exercise therapy is more commonly used, and you need less resources, and I would also like to say less amount of training, whereas manual therapy and cognitive functional therapy need more training, and whereas to apply treatments such as transcranial magnetic stimulation, you need more resources than electrophysical agents. So based on the amount of training and resources, I have classified it into these two approaches. Theoretically, all of these treatments may have an effect on either the peripheral mechanisms or central mechanisms. Say, for example, you take electrophysical agents. The common assumption is that you take ultrasound or, say, particular example, laser. They tend to alter tissue dynamics and they improve healing. They tend to, we assume that they have an effect on the peripheral mechanisms. Now, you talk about pain neuroscience education, which basically involves teaching patients about the physiology of pain with a hope that knowing the knowledge of pain physiology will improve their pain. And ideally, this is something that that is hypothesized to have an effect on central pain mechanisms and psychological factors. So transcranial stimulation is usually done to stimulate the brain centers associated with pain and maybe promote descending pain modulation. So like that, each of these treatments that we use in our clinical practice might have both peripheral effect and or central effect, depending on the modality that you choose. So now I want to draw the attention or just to move towards a question here. Typically, when you do research or when we are in the clinical practice, we are more interested in effectiveness and or probably less interested in mechanisms. But I want to highlight, mechanisms are more important or equally important at least as effectiveness. Now, there is an understanding that most of the physiotherapy treatments, irrespective of what you take, they have certain level of effectiveness, maybe small effect or moderate effect, small to moderate effect. Maybe the next step is for us is to establish evidence on the mechanisms. How does these treatments work, right? That will help us in a way to improve the effectiveness. Say if you have moderate effectiveness, if you know the mechanism, you can tailor the intervention better. That will eventually enhance the effectiveness of the intervention. So that's the point I would like to draw, like to focus on the mechanisms. And the question is that do PT interventions affect pain mechanisms in addition to symptoms? Now we know PT interventions are definitely helpful in symptoms, in symptomatic management. Can they have an effect on mechanisms as well? That is what is the objective of the next few slides or